What's this motion here?
Supination, pronation.
Supination, pronation. Very good. What the bone that moves, notice, is the radius. Okay, the ulna doesn't move. The ulna stays nice and tight. So any muscles that supinate or pronate have to attach to the radius. That's kind of obvious, right? And so now we have pronator teres. Pronator teres attaches to the radius and has two bellies. One belly attaches to the medial epicondyle, and the other one, and we're going to go into this in the lecture as well, just going to get started here. The other one attaches to the ulna, so it kind of comes like this, and between the two bellies, the median nerve travels and can get entrapped right at that location. It can mimic a carpal tunnel syndrome. Now also there's a branch to the median nerve that can get entrapped there as well, called the anterior interosseous nerve. And so we're going to talk about that today. Anterior interosseous nerve is the branch of the median nerve which can get entrapped between the two bellies of the pronator teres. So pronator teres syndrome can entrap the median nerve, anterior interosseous nerve, or both. And it depends on the anatomy of the individual. Where does it branch off as part of that factor? Flip into the other side, so that's in the front here. Pronator teres. In the back, and deep to the wrist extensors is the supinator muscle. And the supinator muscle has a hole in it, a tunnel. It's called the canal fros, or the radial tunnel, and can entrap the posterior branch of the radial nerve. So you get a nerve entrapment here, you get a nerve entrapment here, and you get a nerve entrapment here. And all these are important. By the way, see you with your phone here, this is sometimes called cell phone elbow. I love the term. You're on the cell phone for a very long period of time. What are you doing? You're stretching the ulnar nerve. And so we'll talk about that as we go through the process. So basic anatomy of the elbow. We'll be going, of course, in more detail in lecture. Are there any questions? Medial lateral condyle, olecranon. Right there. Right there. Big old sucker olecranon goes into the olecranon fossa. And so part of what we do when we evaluate is we're going to do Varus and Valgus stress tests, just like we do in the knee and in the fingers, we talk about later. And so with these stress tests, when the elbow is extended, the olecranon is deep inside the olecranon fossa, and so it doesn't put as much stress on the ligaments. When the elbow is flexed, usually we talk about 30 degrees, but really they tested at many different degrees of elbow flexion. Now we take the olecranon out of the olecranon fossa, we require more from the ligaments, and so it's a more sensitive test. Remember, tests of different sensitivity help us to evaluate severity with these things. Remember also, when we're doing these tests, we're not just trying to find out, does it hurt if I do this? We're also trying to find out, is the ligament competent? Does it stop moving in that process? So we push until it stops, and then does it stop? And does it hurt or not in those situations? Okay, radial head. So our wrist extensors, once more. So we have a bunch of wrist extensors. You got extensor carpi radialis longus, extensor carpi radialis brevis, and extensor carpi ulnaris. So extensor carpi radialis brevis also attaches. They all originate from the lateral condyle, but the radialis brevis also has fibers that originate from the posterior aspect of the radial head. And so when I have sudden forces, like for instance, I'm playing, grab one of these, and take one of these back to that guy in the red shirt. There you go. The other shirt. When that happens, so now think with me for a second, I'm playing tennis, and I'm not very good. So the ball is hitting around the edge of the racket instead of the sweet spot. In addition to that, the handle is not the right size for me, so I have to squeeze it extra hard. In addition to that, I'm playing in the rain, and so the ball is wet, and it weighs about 3 times what a normal ball is. And I'm doing it over and over and over again, so what's happening is I'm getting, every time I hit the ball, I'm getting an eccentric contraction of my wrist extensors, as I'm trying to stabilize when I hit the ball. And of course it can tear, and where it often will tear is right at the posterior aspect of the radial head. And so that can pull the radial head posteriorly, adding joint dysfunction to your problem. And so we're going to look for and evaluate and learn how to adjust for a posterior radial head fixation or misalignment or joint dysfunction. With me so far? So we call that tennis elbow. We also call it backhand tennis elbow. We also call it amateur tennis elbow, because if a professional doesn't straighten this out, they don't become professionals. You got to learn how to do backhand without injuring yourself. Professionals, that's a different kind of thing. It's another type of tennis elbow. They get a medial epicondylopathy, a flexor tendinopathy, very good, from tennis serve and the forces associated with tennis serve. And again, we'll be looking at it in more detail in the lecture. Let's work our last up. Are there any questions so far? So, if you remember certain details, much of the rest of this lab and then some of the testing material for this becomes easier. And the first detail to remember is that tennis elbow is the most common cause of elbow pain. And that's the one that's lateral. That's the wrist extensor. So all those things have to go together. That's why